Fourth year students. Today we have a topic, well-known topic, depressive disorders. Those who have been posted or currently on rotation in psychiatry department have been studied about depressive disorders, and I am expecting from whom they will participate interactively. Okay, overview of depressive disorders. We will discuss about the definition, epidemiology, types, diagnostic criteria, etiology, clinical presentation, especially in medical setting, treatment options and recommendation, differential diagnosis, prognosis and comorbidities, if you will be interested to discuss. Okay. I would like you to respond. What do you understand by depression or depressive disorder? Please, students, respond in the chat box. Okay, this is a hint. It's not a sign of personal weakness. But please respond with the proper definition. What is depressive disorder? A condition of mood suppression for more than 14 days. Okay, mood suppression means that mood is low, you are not able to enjoy your life, your pleasurable routine activities for more than 2 weeks consistently. Okay, it's about mood. It's an emotional disorder, change in mood, change in normal activities, good, low self-esteem. Okay. Okay. Loss of daily activities, daily routine, low self-esteem, low energy. Okay, this is all about depression. Depression is a kind of mood disorder, and it is a disorder, not a sign of weakness or not a sign of personal weakness. It's a disorder just like other medical disorders. Okay, this is important thing to understand, and let other people to understand in your surroundings, your friends, your even family members, neighbors, those who consider depression a sign of weakness, they should understand about it. Okay. Why is it important to identify and treat depression? What do you think? Why it is important to identify and treat depression? If you won't treat depression, what would happen? What problems this depressive disorder may cause to the person who is suffering with? Okay, to regain functioning, your normal functioning has been disturbed, people not able to enjoy things or carry on routine activities. So functioning jitni worse हो जाएगी तो उतना problem होगा, economic burden होगा, सोशल बर्डन भी होगा, ठीक है, सारे बर्डन और होगा और उससे डिप्रेशन और सिवियर हो सकता है. एक तो ये रीजन हो गया. देन द पर्सन वेरी गुड कि इन causes of depression, 90% of the cases who attempt suicide or commit suicide suffers with depression. So by treating depression, you can prevent suicide. These are two very good reasons. First, you will have to treat depression because you have to improve the functionality of the person as soon as possible. And you may have to prevent other risk factors that may be lethal, like suicide, and other comorbidities, physical comorbidities that may get prevalent in a depressed population if depression will not be treated, like diabetes, cardiovascular diseases, and other inflammatory disorders, and even chronic depression may lead to dementia as well. Chronic depression may causes structural changes in the brain, in the synapses, in the tracts, and it may lead to neurodegeneration. Okay, you are responding very well. Okay. Okay, without treatment, symptoms can last even for years. Usually, course of depression lasts up to few months, and in the worst cases, it may be as prolonged as years. Appropriate treatment, however, can help most people who suffer from depression. Early treatment, early identification, सबसे पहले तो identify करना है, early identification, early treatment, better prognosis. Yeah, onset, a study conducted in Pakistan found almost 30 to 50% of the population affected with depression in some point of life. It's more prevalent in female, almost twice than that of males, due to certain factors that we have already been discussed when you were being posted in the psychiatry. These could be biological, psychological, and social. Family caregiving, child caregiving role, and the biological factors, the hormonal factors, the brain chemistry. 27 years, usually they present at 27 years of age, means the early age. But depression has bifodal prevalence. Bifodal prevalence in a sense, the first peak comes in the young age, that is 20-30s, and the second peak comes in the elderly in 60s. In elderly, there is transition in state, various states. I think you will have to study it in psychosocial aspects of aging. Highly comorbid with anxiety and substance use disorders. Depression is often comorbid with anxiety and substance use disorders other than medical disorders. Say onset. So how one can identify depression? As few of you commented, it's about feeling low, feeling sad for last 2 weeks. So that 2 weeks is a window. If you have WHO proposed these screening questions with every individual who visits to you with certain physical conditions that are not improving with estimated or given treatment for that disorder. So you have to keep your minds open to see or to screen out your patients for depression. In the coming slides, we will see what are the risk factors that will prompt you to identify or to screen depression, risk factors or risk markers for depression. So first of screening questions you have to inquire is, have you felt down, depressed or hopeless in the last 2 weeks? Persistently. Persistently, the last few weeks, most of the time, either you feel down, depressed or hopeless, or you felt little interest or pleasure in doing things. So yeah, if the person is saying yes to both of the questions, the person may be suffering with depression. So then you have to ask further questions that we will discuss in the coming slides. Okay, other thing, the one more optional question is, have you feel low of energy or fatigue? Since this question is not such specific with depression, so it's an optional question, because low energy and fatigue is also one of the most common symptoms with other physical disorders. Okay. इसमें स्लाइड का थोड़ा सा है कि नहीं बोल रही है. ठीक है, फिजिकल कंप्लेंट्स क्या हो सकती हैं? डिप्रेशन यूजुअली प्रेजेंट्स इन आवर पॉपुलेशन वेयर देयर इज minimum acceptance or acknowledgement for psychiatric conditions. So these disorders may present with physical symptoms only, like sleep disturbances, lack of energy, loss of appetite, weight loss or gain, unexplained headaches, body aches, backaches, stomach aches, digestion problems. Okay, so the depression may be present like those symptoms. See, what is the diagnostic criteria? According to Diagnostic Statistical Manual by American Psychiatric Association, depression may be classified by asking these 9 questions. Among those, 5 questions must be present. 5 things must be present in last 2 weeks. And at least one feature would be from 1 or 2. That is, the person must have irritable mood or low mood or decreased interest or pleasure. So among these 2 features, one must be present to qualify for depression according to DSM criteria in the last 2 weeks. Okay, last 2 weeks is the window time where the person must be depressed or irritable or have low interest in pleasurable activities, that is also known as anhedonia. And other features beside these could be significant weight change. There could be weight gain or weight loss, 5% of the total weight. Okay. Change in sleep. Sleep, usually there is a classical pattern of depression is early morning wakening, almost 2 hours earlier than the usual routine time. And that happens due to dysregulation of the sleep cycle. And which part of the sleep cycle? That is REM or non-REM? That is REM. Okay, there is little non-REM part of the sleep in depressed patients and more REM part of the sleep. That's why they frequently get awakened. Change in activity, there could be psychomotor agitation or retardation. Usually in depression, there is retardation due to lack of energy. They feel retarded in their thoughts. They couldn't process the thoughts very easily, and they couldn't walk or perform physical activities easily. So there may be both psychomotor retardation. And in specific cases, in few specific cases, there could be agitation as well, and where depression is known as atypical depression. There could be fatigue or loss of energy, feeling of worthlessness, I am no more for anything, I can't give benefit to anyone, I am a failure. इस तरह के worthless thoughts or worthless feelings the person may have. Or there may be excessive or inappropriate guilt. Concentration is impaired. The person is not able to focus in any activity like studies, in conversation even. The person may lost the point of conversation where he was actually. So impaired concentration may lead to memory problems, and memory problems are considered one of the features of dementia. However, in this case, the memory problem is due to impaired concentration. The person is not able to register the information due to impaired concentration. So it is called pseudo-dementia, because actually the memory impairment is not the primary thing. It happens due to impaired registration that eventually occurs with impaired concentration. There is indecisiveness, patient is not feeling good to take even minor routine decisions, what to wear, what to cook, how to travel. The normal routine stuff is not able to be decided by the person that once was on the fingertips. There are suicidal thoughts. The person feel life is not worth living. I am a burden for others. It's better to die. So these are the thoughts that comes in the person's mind that may be suffering with depression. See, criteria by International Classification of Disorders, ICD-10, that is a document proposed by WHO, there are 2 parts of these symptoms. First is core features, that is graded as A, and supportive features, that is graded as B. So there, in the core features of depression, there is low mood, lack of interest in pleasurable activities, and low energy. In supportive features, there are sleep, appetite, low self-esteem or confidence, guilt, pessimism. Pessimism is negative thinking. So the person the person is taking every aspect negatively. Automatic negative thoughts are going on in the person's mind. There is impaired concentration that I've already explained with the term pseudo-dementia. There's suicidal thoughts. So depression is divided according to severity as mild, moderate, or severe. Mild, moderate, severe cases are being categorized by these core features and supportive features. In mild, there would be at least two core features and at least two supportive features. Moderate may at least two core features and at least three supportive features, and severe may all core features and at least four supportive features. So this classification will help to manage the patient. In mild cases, there is no need of any medications, just a bit of counseling, advice, life advice to modify the daily routine, include healthy activities like exercise, good diet, leisureable activities, leisure time, good leisure time. So these could be the things that can improve mild state of depression. But for moderate state of depression, the medications and psychotherapy will be required. It will be the preference of the individual. The person would like to take medications only or will like to go with psychotherapy. Both have almost equivalent role in moderate kind of depression. However, in severe cases, there is need of combined therapy. Both medications like antidepressants and psychotherapy, that is CBT, cognitive behavioral therapy, has a role. I think till here you are getting me. Any questions that you would like to ask at this point, or should I continue? Students, I think you are with me. I am going to continue. Okay, these are the types of depressive disorders. Major depressive disorder is also known as unipolar depression because it is without mania, only depression. Disruptive mood dysregulation disorder usually found in children's, where the picture of depression is not such classical as we have studied. Okay, low mood and is tarah. In disruptive mood dysregulation, there is dysregulation of mood. The child or adolescents may present with irritability and disinterest in usual activities, misbehavior with parents or other authority figures. Okay, the disruptive mood, but they have guilt. They have realization of what they are doing is not good, but they can't help it. Persistent depressive disorder, also known as dysthymia, it's a chronic depression that lasts for more than 2 years. And there, the state of depression is not such severe that it compromises the functionality of the individual, but it can be identified with the low state of the mood than usual level and low caliber of working. Premenstrual dysphoric disorder occurs in the menstruation and pre-menstruation time, around the cycle time. Substance or medication-induced depression occurs with psychoactive substance use, means drugs, and medication for other medical conditions like interferon. Interferon therapy may induce depressive features. Steroids may also cause depression, and antiarrhythmic drugs, antihypertensive drugs, and some antibiotics, they may cause depression as well. Depressive disorder due to another medical condition. Another medical condition like diabetes mellitus, like ischemic heart diseases, and other medical conditions that affects the brain area that is controlling or regulating the mood, like the limbic system, the right hemisphere. Okay? It may be compromised by trauma, by infection, by inflammatory conditions. There could be epilepsy, Parkinson's disease, herpes. Okay, these could be the conditions. HIV directly by psychosocial factors and by their drugs and treatment options. Other specified depressive disorders that doesn't classify in the same diagnostic criteria are known as other specified depressive disorders. Unspecified depressive disorders, the mood is depressed, but the overall criteria is not fulfilled. So these are the diagnosis of types of depressive disorder. And there could be seasonal affective disorder. Depression only occurs in certain seasons like winters, where there is low light and there is disruption in the level of melatonin. Okay. Prevalence of depression in medical setting. See, there are other psychiatric conditions as well, but what we are focused with depression and anxiety. Because depression most commonly presents in general practice with GPs. See, people visits them with multiple somatic complaints, unexplained somatic complaints for a long time with normal investigations and इस तरह. So somatoform disorders में depression is very prevalent. So they presents with general practice GPs, and they may even present in casualty with suicidal attempts and all that. And they may present in even medical and outpatient department with somatic complaints and even medical surgical. They may get hospitalized in medical surgical inpatients with severe, with the presentation of undiagnosed medical conditions, or they may even present with substance use conditions where they need medical care, medical or surgical care. अच्छा, presentation of depressive disorder in medical setting. ठीक है, if depression is not identified, ठीक है, and so they may present like this medically unexplained symptoms. They may present like adherence issue. The person is not taking medicine properly. The person is not motivated to do anything to comply with lifestyle modification or and all that. So you will find, if you will find adherence issues, motivation issues, or if you will find unexplained medical symptoms, or if you will find unexplained exaggeration or exacerbation in the previous medical condition for no identified reason, then you would definitely think about ruling out depressive disorder. Okay. Causes of psychiatric comorbidity in medically ill person. Depressive disorder may be found them in by chance, and the psychiatric disorder might cause the medical condition, maybe the depression or other psychiatric disorder. Here we are talking more about depression. So by psychiatric disorder, it means depression. The depression could be the first thing that come in the patient, but it was undiagnosed or unattended, and that lead to the other medical condition. Like as I have already told you, chronic depression may cause other medical conditions like diabetes, like ischemic heart diseases, and other inflammatory disorders. Or even depressive disorder may cause substance use disorder, and with substance disorder, there may be other medical conditions that may arise, like with alcohol, there may be liver problems, and opioid use, there may be respiratory problems or GI problems. The medical condition might cause the psychiatric disorder. So first the medical condition appeared, and then it led to the depressive disorder. So depression and medical conditions have the bicausal presentation. Both may be the cause and effect of each other. So it is something that you have to take care of. If one condition is not treated, it may lead to other conditions, and ultimately both conditions may impair the prognosis of each other. WHO recommended to rule out depression because and treat early, because it may compromise the morbidity or complicate the prognosis of the physical disorders by up to 42%. If depression is not identified or treated, it may increase the morbidity or mortality rate up to 42%. So it is very important. Traditional, अच्छा ये क्या है? Dualistic categories है of mental or physical illness. Initial time, in very initial time, the physical symptoms and psychiatric symptoms were taken as two separate entities, and they were not be attended together. But with the time, they have realized that body and mind things are integrated; they are not separated. So initial classification, and that is still going on for the understanding purpose. If the primary thing is the body pathology, and body pathology means some physical disorder. If patient is primarily suffering with some physical disorder, behaves, does the person comply with your advices? Those all factors comes in the psychological factors. And if you cater those factors in your routine assessment, then you will be able to easily pick any psychological disturbances in your patient. Social factors are interpersonal and social and occupational circumstances relating to the healthcare system. So it's very important to get in loop of family members of the person, because family members, reliable family members, concerned family members, maybe your partner is to promote the good health with your patient by promoting treatment compliance, treatment adherence, and visiting to you with the patient. Who is at risk for developing depression? Family members means a person who is suffering with depression. So the family members are at risk. There may be biological risk, genetic predisposition भी हो सकती है, and psychosocial stressors भी हो सकते हैं. So family members of depressed person are at risk. Those with negative temperaments, those who usually process the things with negative thinking process, and those who generally frustrate easily or get irritated or frustrated easily. So the negative temperament people may get depression, may at risk of developing depression due to lower frustration threshold. Childhood experiences, adverse childhood experiences like parental loss, neglect, and other psychosocial problems in the childhood, like abuse, physical, social, or sexual abuse. Stressful life events, recent or past stressful life events, having few friends or other personal relationships, other major disorders or medical conditions, as we have already discussed, environmental factors, poverty, lack of usual resources, unemployment, nutritional deficiencies, environmental restraints. ठीक है, तो ये सारे environmental conditions में. Okay. Medical conditions that may cause depressive disorder. Okay, we have discussed carcinoma, especially pancreatic carcinoma, infections, cerebral infections, neurological disorders, diabetes mellitus, thyroid disorders, especially hypothyroidism, Addison's disease, and SLE. These could lead to depressive disorder. Drugs, as we have discussed, these are not. This is not the full list. There could be others, but these are the common drugs that may lead to depression as a side effect: anti-Parkinsonian agent, anticholinergic agent, levodopa, cardiovascular drugs, steroids, and miscellaneous drugs. Okay. Ecological factors we have discussed in who are at risk, who are early adverse experiences according to biopsychosocial model. Genetic predisposition hai, early adverse experiences hai. See, there is not a single risk factor, there is not a single causal factor that will lead directly to depression. There are multiple factors that may constellate to produce depression. So there may be early adverse experiences, genetic predisposition, cognitive vulnerabilities, those who have negative thinking process, emotional vulnerabilities, those who are very emotional, take things with impulsivity and all that, biological vulnerabilities, interpersonal vulnerabilities, poor family dynamics, lack of social support. ये सारी चीजें मिलके they may cause depression. And in those who maybe suffer with depression but have not a list of such causal factors, so there is good prognosis. And those with a number of risk factors have relatively poor prognosis, considering if they are complying with the doctor's advice, taking medicine with full adherence, and visiting the psychologist to take CBT and other intensive psychological therapies and involving in social activities. So there could be good prognosis. So yeah, biological vulnerability means the structures which are involved. As you already know, limbic system is involved with emotional processing. So altered amygdala volume and activity, there could be lower hippocampus volume, dysregulation of the HP axis, genetic and nurture का equal role है तकरीबन in the causation of disorders. These changes in the brain may be present in by genes, and they may be present by nature, by nurture, means के continuous stressors and other child adverse early time adversities may lead to such brain changes. There may be depletion of monoamines like serotonin, dopamine, norepinephrine. So yes, stress, if there is stress, there is dysregulation of HP axis. Psychosocial vulnerability includes, as we have discussed, temperament, negative belief system. Which a cognitive triad concept has been given by Aaron Beck. Aaron Beck is a psychologist. He has been worked in the investigation of psychological processes in the depressed population, and he found a triad of environment, future, and self. The depressed person feels oneself low, worthless, failure, and feels the future is gloomy, dark, and the environment is hostile. So this is the negative cognitive triad for depressed patients that was introduced by Beck. And by identifying the negative assumptions of the person in this triad, the psychologist can work well with the person to restructure those negative assumptions. Impairment in social skills and relationship disturbances. Chronic disturbance in the social skills or relationships may cause the person vulnerable to develop depression. Assessment of depression in medical setting. What are the questions you will ask, and how will you suspect the depression? Is there evidence of confusion? If you are, these may be used to rule out depression. From other departments, we often get called to come to rule out depression because the person is not responding well, person is not talking, person is mute and all that. So that muteness and that confusion is not depression. It could be hypoactive type of delirium, acute confusion in the state that may happen due to underlying medical condition or surgical condition. How does the patient describe his mood is very important. The depressed patient may just false smiling. So you have to see the person either look depressed or not. If the depression look means facial expressions, the psychomotor retardation. If you are observing such signs in the person, then it could be depression. So this couldn't be depression. This could be the vegetative symptoms of other physical conditions. Lack of reactivity, flat emotionless. Lack of reactivity means the person is not able to connect with the situation. Means if the situation is pleasurable, the person is not able to connect. The person is not able to feel happy. So that lack of reactivity may found in depression usually. Collateral information आपके लिए very important to think about the severity, duration, and temporal relationship. Means कि what came first, this mood features or the physical disorder. And duration, as we have already know, कि this is 2 weeks at least. So step care approach is important. Stepped care lines. The concept of stepped care approach is to provide the optimum care, neither more intensive and neither less intensive. The appropriate or optimum care to be provided to the appropriate candidate. Means if the person need only identification, so the person is without any symptoms, but person is at risk of developing any condition. So first step of step care is to prevent any condition with which the person is vulnerable and promote healthy lifestyle. The first step of step care approach is prevention and promotion. Means here we are talking about depression. So in the vulnerable population, like one who is with chronic medical conditions like epilepsy, terminal illness, cancer. So these are Parkinson's. So these are the vulnerable population. So in which we have to screen out depression and treat accordingly if the person is suffering with depression. So prevention and promotion, the next step is recognition in primary care. If the person is taking treatment in the primary care, means you have to identify the depressive features and assess its severity via investigations and accordingly intervene it. As we have already discussed, according to the state of the depression, we provide intervention, either only non-pharmacological intervention, pharmacological, or both. Secondary or specialist services will be needed if the depression is complex, is not responding to treatment provided by primary care physicians like GPs or other non-specialist health professionals other than psychiatrists. So the secondary or specialist services is needed when specialist services needed when the depression is very severe, means the person is suicidal, patient is not manageable at outpatient basis, or the person needs ECT, or the depression is comorbid with other medical conditions, and there is a strong risk for having serious drug interactions. So in those cases, a specialist care is needed. Prevention of depression in medically ill. 3 main strategies ये हैं कि identify those at risk, early identification, minimize the negative effect of primary illness by providing good medical and nursing care, detect and treat effectively at the early phase. I hope you are with me. If you or someone you know has symptoms of depression, ठीक है, अब अगर आपने identify किया है being a doctor, ठीक है, and you are now educated about the conditions of depression, the sign and symptoms of depression with which the person may present. So then your duty is to guide the person to take action. So what actions could be? First step is physical examination by our doctor. Let the person examined by our doctor. to see if there are any physical signs of any other condition. Talk things over with an understanding friend, family members. Be yourself available for the person who is depressed. Go to the mental health care facility, talk to mental health professional. Don't expect too much of yourself until your energy and mood improve. Say if someone is suffering with, to provide a relaxing environment, calming down environment. Take ask them to take a break, get some exercise, avoid extra stress and big changes. Antidepressants, keep prescription, उसकी recommendation in a couple of slides we will discuss. Base a choice of antidepressant on the patient's prior response. If the person has already taken some antidepressant, see the response and select one that has already been tested and the person responded. Patient and clinician preference, okay, it's a priority. What the patient want to start. If the person doesn't want to take any medicine that may cause weight gain, that may cause sedation, so you have to value the patient's preference. And also being a clinician, you have to discuss the options with the patient. If you think that certain antidepressant that the person is willing to start may cause certain drug interactions, if the person is already with other medications, then you have to discuss the preference. So means you have to negotiate the best treatment option for your patient. Explore any potential side effects that could happen. Cost, whether it is affordable or whether you can arrange them through your setting. Choose any class of antidepressants. So yeah, any class we can choose, but as a first line treatment of depression, usually SSRI is being recommended because of narrow side effect profile. Ask patients from different ethnic groups about their treatment preference for depression. Consider about discontinuation. Okay? Sudden withdrawal or sudden stopping of treatment, skipping dose may cause discontinuation syndrome. So guide them, but it doesn't mean the medicine is addictive. So this is a common misconception regarding psychotropics. Okay. Practice recommendations here, most people need to be on antidepressant medication for at least 6 to 9 months after first episode of depression. It may take 2 to 6 weeks to see any improvement. See, few patients could see better result only in 2 weeks, but it may take 6 weeks as well in few individuals. It is very important to take the medication as prescribed even after they start feeling better. You have to continue the medication even after feeling better as a maintenance therapy. And that maintenance therapy duration is 6 to 9 months after first episode of depression. And after consecutive episodes, there could be more duration of maintenance therapy. They should not stop taking the medication without calling the provider first. Means the person shouldn't stop after taking medicine without discussing with the prescriber or the doctor. Changing the dose or dose schedule can help manage side effects. Say if the individual is having sedative side effects or any other side effects, it's better to discuss with the doctor to arrange the dose. Means sedative medicine dose may be taken at the night time. Okay. See, these are the few antidepressant classes, TCAs, SSRIs. These are the drugs. These are the medicines that comes in the class. These are the antidepressants. There is the minimum dose of antidepressant. There is the maximum dose of antidepressant. In a special population like sensitive population, means pregnant females, lactating females, post-stroke depression, in those conditions, there is particular recommendation regarding antidepressants, means which antidepressant is most appropriate for those populations. Certainly, you can see is most appropriate in pregnant or lactating females. SSRIs, you can easily see is most prevalent or most easy to use in every case. But selection of SSRI is variable. So this is for your interest. Certainly you can see is in every group. Major neurotransmitters that are compromised. Say usually in depression, monoamines depleted, monoamines deficiency is there. Monoamines means norepinephrine, serotonin, and dopamine. Say here with time, with the advancement of time, there are novel medications that target specific neurotransmitter. If the person has deficit in certain domain, like if the person has more problem with energy level, then you can prescribe with the antidepressant that has more role on norepinephrine level. Likewise, if the person has poor motivation, poor drive, then you can give them antidepressant which has more effect on dopamine, that is DNRI. Okay, DNRI may be used in the person who have lack of drive, and mostly those who are trying to quit certain drugs like smoke to nicotine, and they are not able to quit due to lack of drive, then here DNRI, dopamine antidepressants have a role. Those who have irritability issues, anger issues, impulsivity issues, though more issues with their temperament, here is the role of serotonin. Otherwise, they have overlapping role in various domains. So, selection of antidepressants is according to the symptom profile. The antidepressant must target the specific neurotransmitters. So here is the example of the antidepressants which could target particular neurotransmitters. So yeah, we are done. Those who are interested may take this scenario to answer. A 23-year-old engineering student of reputed university is feeling sad for a few days. Once he thinks of his broken guitar, spoiled accidentally by his nephew. He otherwise remains engaged in studies and social activities, but at times of loneliness, deplores over it. With what is he suffering with? So, according to your understanding, what would you like to respond, please? Say natural response. That is so right. What things make you to think about it? That is the for a few days. Depression is for 2 weeks at least, and it is not persistent because the student engages with studies and social activities and only feels sad when he thinks about it. Okay, that is normal sadness. Okay, that is normal sadness. The guitar that was his favorite guitar, and that suddenly broken up. That is something natural. But if there would be two weeks and the person is not able to study or engage in social activities, then it will be depression. Any questions? Any questions? Otherwise, okay, we have to conclude this session because time is also 11:30. Any questions, students, that you would like to ask? No more questions? Chale, thank you. Allah Hafiz.